The final speaker, another doctor, Dr. Andrew Baum, is going to give us some perspectives from what I might consider the Citi.
Well, thank you for your attention today, and I'd like to thank my two colleagues for giving a very nice overview of some of the key thematics. And without what doubt, is an incredibly exciting time for medicine and for those companies who are sponsoring those changes, and the investors in those companies are going to have very significant returns. And I want to talk about just one of those topics which both the previous speakers alluded to, and that topic is immunotherapy and cancer. Now, about 2 years ago, we published a fairly high-profile report called The Beginning of the End of Cancer. And the title was meant to be provocative, but I really do mean that. I think we are very much at the beginning of the end of cancer. Now, think about that for just a second. There's been some very significant breakthroughs and paradigm shifts over the last 10, 15 years. And in fact, HIV was named as one of them. Previously, we had hospital wards of HIV patients dying within a matter of 12 months or less. But think about cancer. 1 in 4 individuals will die from cancer. 1 in 3 individuals will experience cancer during their lifetime. So if we are able to effect a meaningful change, as I think we will be in cancer, this has dramatic implications for society, humanity, and the economy. All right, so let me just give you a little bit of background. What is immunotherapy for those of you who are not familiar with it? Immunotherapy is triggering the body's own immune system in order to suppress or delete malignant cells in order to make cancer either controllable or eliminated. Now, this is not a new idea. It's been around since about 1850, when German doctors first noticed that patients' tumors that got infected, occasionally the tumor would vanish, and not just the infected tumor, but the other tumors the patient had in their body. We've also noticed that patients who have immunodeficiency disorders, so problems with their immune system like HIV, experience a whole raft of very strange tumor types. Again, this idea of the role of our immune system, as well as wiping out bugs and colds, is acting as a security guard and clobbering cancer cells when they arise. And sometimes, for some reasons, they don't work. Now, let's see if I can operate this. There we go. I'm going to tell you how these drugs work in just a second, but first of all, I want to just make sure I've made clear the difference between immunotherapy in terms of the treatment effect and traditional chemotherapies. And if you're a drug geek like me, this is the kind of charts that we look at. And what you'll see is on the y-axis, we've got the percentage of patients alive at the beginning of a trial. So up here, everyone's alive. And then you've got time along the x-axis. And if you just look at the black line, what you see is with time, basically the population dies. Now, if we give these patients an active drug, like a traditional chemotherapy or even a drug like Avastin, there is a shift in that curve to the right. So it means at any given time, there's more patients alive. But invariably, these patients go on to die. So both from a society point of view, as well as from a financial point of view, it's a lot of money sometimes to pay for a small amount of gain. Now, what we're talking about here with immunotherapy is you have a cohort of patients who just don't die. They carry on living and living and living. And this isn't with continued treatment. This is with a matter of 4, 8 infusions, maybe over 1 or 2 years, affecting a significant change in outcome. And just to give you some idea that this isn't just a pretty picture, an ideal, it's a reality, and many referred to it earlier, the first of the contemporary series of immunotherapy drugs, a drug called Yervoy, from a competing company to Menes, was first put into man about 10 years ago. And 20% of those patients who had end-stage skin cancer, who normally would be dead at about 6 months, are still alive today, 10 years later. Now, that's only after 4 to 8 injections. So that's really something very significant that we haven't seen before. So how do these drugs work? Well, this is a schematic that briefly summarizes. The immune system is held in check in our bodies through a mechanism of tolerance. The reason being that if we had an active immune system the whole time, we'd run into a whole gamut of autoimmune disorders, asthma, lupus, rheumatoid arthritis, and so on and so forth. So there needs to be some mechanism to put the brakes on. However, in a patient with cancer, we actually don't want those brakes. We want to unlock the brakes. And the brake, which is exemplified in this picture, is one that many again refer to, a brake called PD-1, which basically works by the cancer cell, which is here, having a little marker on it called a PDL1 or ligand, and it binds the PD1 receptor on the T cell and basically turns off the T cell. It inactivates it. So what we want to do in order to get the T cell active again is break that connection by either blocking the PDL1 or the PD1 and affecting a change. And this collection of molecules are known as checkpoint inhibitors, and PD1 is just really one of them. There's a series of other similar so-called co-inhibitory checkpoints like PD1 that are brakes that you want to take the brakes off. But similarly, there's a number of other approaches which are, if you like, stimulators, which trigger the immune system to do more by binding to the T cell. And those include drugs, and you'll see them increasingly in the press, names like OX40, names like CD137. And then aside from these molecules, there's even more approaches. There's therapeutic vaccines, which trigger the immune system to make a response. There's adoptive cell therapies. And really, we're going to see an expansion of all these treatment modalities over the next 3 to 5 years. Now, what does this mean for society? And you'll see on this chart the fairly good successes we've had with cancer mortality over the last 3 or 4 decades. And you see an increase in cancers over the period, the cancer deaths over the period, and then a drop falling here, and then the question is, what's going to happen during this period? Now, some of this is smoking cessation, better living conditions, obesity control potentially beginning to come in now, but the real impact of therapeutic interventions could be enormous for many cancers over the coming period. So how applicable is this? How many cancers? Is it just skin cancer, which is a pretty small number of patients? Or are we talking the much more common cancers like breast cancer or lung cancer, which claim an awful lot more lives every year? Well, our belief from the get-go and increasingly validated by the data is that immunotherapy is going to have a pivotal position within 60% plus of both solid and also hematologic or blood tumors. Now, the initial data came out, and you see there's a couple of ellipses here which represent the size of the market for both solid tumors and for blood cancers. The initial data came out in skin cancer and renal cancer and lung cancer. But since this initial data came out, we've had further signals reinforcing efficacy in everything from ovarian to prostate to many of the hematologic cancers like NHL or CLL or so on and so forth. So the applicability of immunotherapy across the significant percentage of the tumor types which afflict mankind is highly important. Now, how does the industry make money from this? Well, that's the other part of my job. And there are a number of drivers. Obviously, the price of these agents is absolutely critical, and I think it should be a fervent discussion during our panel discussion. The other question is, how long do we give these drugs? Do you only give it a month, 6 months, 12 months? Or do we have maintenance therapy? And we also have combination therapies, because what's pretty clear, if we go back to the chart that I showed you at the beginning, we're not getting 100% success, because there are clearly, if we had 100% success, then all these patients would be alive there. So what we're seeing in most of the tumors where we use just one drug is we're seeing only about 20% of patients, maybe 30, 40% in some tumors are having a maintained response, but we're not helping the other 60%, which means we need to do something else, be it another drug or another intervention. The size of the market is substantial. I won't take you through the chart because we're slightly tight on time. Our initial estimate that we published in our early work was approximately about $35 billion market potential. Consensus at that time was close to zero. I would say that my initial $35 billion estimate on the back of that time was a limited series of signals in limited indications, was actually an underestimate. I think it's probably closer to about 45 billion at peak. Now that's an important topic subject to lots of pushes and pulls in terms of pricing and competition between the different players, but I think that's the order of magnitude we're looking at for a disease that affects 1 in 4. Now, who wins from an investment point of view? Well, paradoxically, it's a lot easier to predict the size of the market based on the science and the signals we're getting than the market share. And that's because we've got multiple sponsors developing many of these drugs in lots of different areas. And we're living, fortunately, in a time when the regulator is recognizing the life-changing natures of these therapies and doing everything in its power to accelerate clinical development. And that means the barriers of entry are relatively low. And so a company which today looks like it has a very limited presence in immunotherapy, tomorrow could be the market leader. So I struggle, and I'm very open in telling my clients that I struggle in determining who necessarily is going to be the dominant player in T+5, T+7 years. And my recommendation is you buy a basket of names. Alternatively, you look for those stocks where there's nothing being priced in for immuno-oncology portfolios. I've listed on the chart here 4 of the larger sponsors. There are others now, as you will see in a second. This chart shows along the top the major sponsors of immunotherapy within the industry among the multinationals. This chart was put together probably about 6 months ago. It is woefully out of date, and many of the companies which had 0 in many of the boxes would now have lots and lots of ticks. Again, underscoring the point that competition and market share is really a very difficult problem to solve. So in the interest of time, I'm going to stop here. And I think all 3 of us would welcome any questions on both the broader dimensions that were laid out by Robert, or indeed industry's involvement, or from my side, immunotherapy. Over to our chairman.
Great.